Good morning, everyone. Welcome to Internal Medicine Grand Rounds. It's my pleasure this morning to introduce our speaker, Dr. Irine Vodkin. Dr. Vodkin attended medical school at the University of California, San Francisco, and then completed her internal medicine internship and residency at Stanford University Hospital. We were fortunate to recruit her to UCSD for her fellowship in gastroenterology, and she stayed on to complete a fellowship in transplant hepatology before joining our faculty. Dr. Vodkin is an assistant clinical professor in the Division of Gastroenterology and serves as the program director for the Transplant Hepatology Fellowship. She is the PI on multiple investigator-initiated and industry-sponsored trials and has published numerous peer-reviewed articles on topics related to transplant hepatology. She received the Excellence in Clinical Teaching Award in 2019. We're really fortunate to have her here this morning to speak to us about alcohol and liver disease. Dr. Vodkin, thank you so much.
Hi, everybody. So I think before we get started, I'm going to tell you a little bit about my journey to hepatology, which hopefully will make the presentation make more sense. So I entered medical school really thinking that I was going to be a geriatrician, but by second year of medical school, I had a continuity clinic in liver transplant at CPMC. And I was really amazed. These were the sickest patients I'd ever seen. And after transplant, they were just transformed. So it was very amazing to see the transformation that transplant afforded these patients. And at the same time, we were going through a lot of the physiology since it was second year. So I really enjoyed the physiology of the gut and the liver. And, obviously, we were also able to see a lot of endoscopy videos, and there's a nice repository of endoscopy videos online where you can see parasites set to classical music. So obviously I was inspired by that as well. And I was pretty set, internal medicine, great, we'll get to hepatology later. But I wound up really enjoying my psychiatry rotation. And I actually did a sub-internship in addiction psychiatry during my fourth year. And then I just did not know what to do. So I actually wound up interviewing both for internal medicine and psychiatry. And because I was interviewing at the programs at some of the same centers. I actually had two outfits. I did my hair differently. I did basically everything shy of having a fake mustache so that people wouldn't know I was interviewing for both. But eventually I really felt like I connected to internal medicine more. And my first love was really hepatology. So that is what I eventually wound up doing. But fast forward to now, I still love hepatology and I love addiction. And I really think that transplant is incredible and life-altering, and really appreciate the life-saving magic of transplant. But at the same time, in my non-transplant clinics and in my pre and post-transplant clinics, I really, really still appreciate seeing alcoholic liver disease. And I love to see how patients can change their lives through their own self-efficacy. And I've had some of my patients now going on 7 and 8 years and have really seen the incredible journeys that they've taken alone or with their families in order to better their health. So I think that's kind of the intro to this talk, and we will be talking about liver disease, but we will also be talking about alcohol. And I think that the two are important to think about both together and separately. As a disclaimer or disclosure is I am not a psychiatrist or a psychologist, even though I toyed with being one for a brief period of time. We are going to talk about alcohol use disorder. the global and US burden of alcohol-associated disease. We will also, since I'm a hepatologist, talk about alcohol-related liver disease and mortality, alcoholic hepatitis and transplantation. And then at the end, we'll review treatment of alcohol use disorder, including both behavioral and medication therapy. And I do have too many slides, so we'll hopefully get through most of them. So to begin with, we should have a shared language when we speak about alcohol. And the NIAAA definitions to be aware of are for heavy and alcohol use and binge drinking. So heavy alcohol is consuming more than 4 drinks on a day or more than 14 drinks per week for males, or 3 drinks on a day, or more than 3 drinks on a day, and more than 7 drinks per week for females. Binge drinking is 5 or more for males and 4 or more for females in a 2-hour period. It's also important to know what a standard drink is, because when we're thinking about different studies that come from the US or Europe or Australia, which have the bulk of our alcoholic liver disease research, the standard drink sizes are actually quite different. So a US standard drink is 14 grams of pure alcohol. Australia is 10, the UK is 8, and Sweden is 12. So most studies do try to report the actual grams of alcohol use when they're evaluating patients, as opposed to an actual standard drink. Alcohol use disorder is a chronic medical condition that's characterized by inability to stop or control alcohol use despite adverse social, occupational, or health consequences. And this disease causes lasting changes in the brain, which result in perpetuation of the disease and incur the vulnerability to relapse. So this is really, truly a brain disease. And the DSM-4 describes alcohol abuse and alcohol dependence, but the more updated definition in the DSM-5 actually groups both of these under the umbrella term of alcohol use disorder, and just defines mild, moderate, and severe subclassifications. So when we're thinking about alcohol use disorder, what we are thinking about is these 3 different domains. The first domain is loss of control, which is really cravings and intending to drink a certain amount, but over a period of time, drinking more than you expected, drinking longer than you expected. The second domain of this disorder is adverse consequences. So this is recurrent alcohol use causing problems with your job, with your school, with your home life. And then the physiologic effects. This is your tolerance and your withdrawal. Mild will be just 2 of these or 3. Moderate is 4 to 5, and severe is greater than or equal to 6 of these categories. So what about the global burden of disease? So the global burden of disease for 1990 to 2016 in 195 countries was recently published in 2016. And alcohol was found to be the leading risk factor for premature death and disability amongst patients aged 15 to 48. 3.8% of deaths in females and 12 deaths in males in this age group were attributable to alcohol use. And the risk of health loss rose with increasing amount of daily drinking above 0. So when we're thinking about safe limits, even a daily drink may incur some detrimental health effects. What about cirrhosis? Well, according to the WHO, alcohol contributes to about 48% of cases of cirrhosis worldwide. And that is above really all other causes of alcohol attributable liver diseases. So more than diseases of the pharynx, throat injury, pancreatitis. Again, 48% of cases of cirrhosis worldwide have an attributable fraction of alcohol. What about the US? Well, 15 million people in the United States have alcohol use disorder, which is about 5.3% of this age group, which I really find to be pretty shocking. 95% of people die from alcohol-related causes annually, and this is the 3rd leading preventable cause of death in the US. And even when patients are not drinking, 29% of overall driving fatalities are results of alcohol. So even if you're not being affected by alcohol yourself, you are on the road with people who are. And obviously there's a lot of focus right now on the opiate epidemic, but you should also be aware that alcohol contributes to 22% of overdose deaths related to prescription opioids. Alcohol use disorder is increasing. So there was a group of national data sets from 2001 to 2002, and again in 2012 to 2013 that looked at over 30,000 survey respondents. And what they found was that the alcohol use disorder and high-risk drinking were both increasing. When this study looked at alcohol use disorder, this was still using the DSM-4 definition. So this was patients who fell into either the abuse or dependence categories. And you can see that the alcohol use disorder prevalence went from 8 to 12% over that time period. And the most alarming increases were in women, in patients who were Hispanic or Black, in adults over 65, over 106.7% increase in the prevalence. And in those earning incomes of 20,000 or less, there was a rise in 65% in prevalence. And realistically, why is that so possible? Well, if you want to drink a fifth of vodka a day, you can do so for as little as $30 a week. If a pint will do, that's $15 a week. It takes $58 to smoke a pack a day. So alcohol is very, very cheap. And we just touched upon the difference in rise in alcohol use disorder amongst females versus males. Well, there's also been a reduction in sex-based differences in alcohol use. So if you're looking at cohorts that were born in the 1900s, males outnumbered females roughly 3 to 1 across all measures of alcohol consumption and high-risk drinking. But now, if you're looking at the ratios for more contemporary cohorts, the ratios are approaching 1 to 1. And what has COVID done? I think all of us have the sense that we're just seeing so much more alcohol now due to COVID. And some of this is starting to bear out in the literature as well. Between March 2020 and September 2020, there were $41 billion in alcohol sales, representing an increase of 20% compared to the same period in 2019. And on average, alcohol was consumed 1 day more per month by 3 out of 4 adults. In particular, women had more increase in heavy drinking days. As far as what that's done to our hospitals, a single center retrospective study from New York found the inpatient liver census with alcoholic liver disease increased from 38% to 49%. And their takeaway message from the article was basically to brace ourselves. So let's shift gears a little bit to alcohol-associated liver disease. And this is a list from the recent AASLD guideline for factors affecting the risk of alcoholic liver disease. What will increase your risk? Well, alcohol dose above the threshold of 1 drink per day for women and 2 drinks per day for men. Different patterns of consumption may contribute. Smoking, obesity, a presence of a comorbid condition like viral hepatitis or hemochromatosis, NAFLD, certain genetic polymorphisms as well. And there is a very clear sex difference between women and men as well. There's also some ameliorating factors which are being explored, including coffee, and very equivocal data on what kind of alcohol you consume and whether or not patients with a high BMI are able to consume even modest amounts of alcohol. But let's look at that sex-based difference again a little bit more closely. So female drinkers are at a greater risk of alcoholic liver disease than males. They are more likely to develop severe disease. They have more rapid progression of disease in just under half the time. They develop alcoholic liver disease at about half the dose. So for men, about 30 to 40 grams per day will give you more of a pure alcoholic liver disease or cirrhosis. For female drinkers, it's 20 grams per day. Relative risk of developing cirrhosis amongst heavy drinkers, 7 in men, 17 in females. And women are more likely to die once they develop decompensated cirrhosis, independent of abstinence rates. So again, closing that gap in drinking and the increase incidence of alcohol use disorder in females is going to be an ongoing problem in alcoholic liver disease as well. Unfortunately, these patients are referred to hepatology quite late. So in a worldwide study of referrals to specialty care, 3.8% of patients that were actually referred with early liver disease had alcoholic liver disease. Patients with alcoholic liver disease were 14 times more likely to be seen with advanced stage disease compared to patients with hepatitis C. This bore out in a US-based cohort as well. So if you were presenting with alcoholic liver disease, you were much more likely to present with cirrhosis compared to your NAFLD compatriots. An alcoholic diagnosis was associated with the presence of cirrhosis by over 4-fold compared to NAFLD. So again, we're seeing these patients, we're seeing more of them, but we're also seeing them late in the game. And the prevalence of cirrhosis across the board and the prevalence of cirrhosis due to alcohol is increasing. This is a privately insured cohort of almost 300,000 patients who had cirrhosis. 36% had alcoholic cirrhosis. Again, this is a US-based cohort with private insurance. And you can see that the prevalence rose for cirrhosis across the board. And the range here was from 0.19 to 0.27%. But if you're looking at different studies, including other population-based cohorts or VA studies, the prevalence was up to 1%. If you're looking at ALD cirrhosis, across this group, it rose to 0.1%, but the range across the groups is 0.1 to 0.3%. But the problem is that even though all of cirrhosis diagnoses are rising, alcoholic liver disease patients that presented with cirrhosis were sicker. They were admitted and readmitted more often, and they incurred nearly double the per person healthcare costs. So there was a huge burden of hospitalizations from this patient population. And not just hospitalizations. This translates directly into mortality. Among all cirrhosis deaths in 2015, almost 50% were alcohol related. And you can see here in this graph, in the red boxes, that is the death rate rising for alcoholic liver disease. It is dropping for hepatitis C as expected due to the advent of very effective therapies. And you can see hepatitis B and NAFLD way down at the bottom for deaths. And who is it rising in? Well, unfortunately, the proportion of alcohol related cirrhosis is rising in our younger patients, and so is mortality. If you are seeing a young patient for cirrhosis, it is almost certain, again, 2/3 will be due to alcohol. Mortality in alcoholic cirrhosis in 25 to 34-year-olds grew more than 10% annually between 2009 and 2016. So even though they're still not making up the bulk of alcoholic liver disease and alcoholic cirrhosis diagnoses, their death rates are rising, which is obviously of high concern. So this is alcoholic hepatitis specifically. This is another database study looking at NHANES, the National Inpatient Sample in UNOS. 18% of alcoholic liver disease related admissions were for alcoholic hepatitis. And you can see that steady rise in the less than 35-year-old group. The increase was over 2-fold between 2006 and 2016. And patients who were female or Hispanic had increased risk of presenting with acute on chronic liver failure by 8 and 17% respectively. And acute on chronic liver failure, if you're not familiar with that term, is basically measured as organ failures. So these patients are very, very sick. And obviously, our alcoholic hepatitis patients tend to be a little bit sicker than some of our other cirrhosis admissions, and the ACLF rates were seen certainly higher in alcoholic hepatitis versus cirrhosis. So again, sicker patients. So if you feel like you are rounding at Hillcrest and you are seeing more and more young people presenting with alcoholic hepatitis, it is not in your head. That is actually what is happening. So as we're seeing more of these patients, we are also transplanting alcoholic liver disease more. It is the second leading cause of liver transplant listing in the United States, making up about 31% of liver transplants. And you can see that it is the purple stars crosses. You can see that line uptick. You can see the hepatitis C line plummet. And just above alcohol is other unknown, and that group is cryptogenic cirrhosis and fatty liver. But what about alcoholic hepatitis? So again, we are all familiar and comfortable with transplantation for alcoholic liver disease, but what about alcoholic hepatitis? Well, in 1996, a survey of 85 of liver programs found that 85% of liver transplant programs in the US said that they require over 6 months of abstinence for liver transplant. But severe alcoholic hepatitis, unresponsive to steroid therapy, carries a risk of mortality. And that risk of mortality is about 85% at 6 months. And the mortality for these patients frequently occurs in the first 2 months. This is not compatible with the 6-month rule. My favorite of all of the different prognostic scores is the Madry's Leo nomograms. In A is the 2-month and in B is the 6-month mortality prediction. But if you calculate the Madry's on admission and then you calculate their allele after steroid response versus non-response, you can see some patients will be upwards of 90% mortality at 2 months, and a wider group at that 6 months. So again, this is not compatible with the 6 months rule. Where does the 6-month rule even come from? Well, obscure origins in the 90s, and UNOS actually evaluated adopting this rule, but they did not feel that they could hold up to a legal argument. So they left it up to the transplant centers to decide what their protocols would be for abstinence. And really, it doesn't make sense. So stable sobriety is measured in years. It's not measured in months. And the 6-month rule has a lot of weakness. It's completely arbitrary, and it does not take into account other predictive factors. So high risk factors like drug dependence, depression, number of quit attempts, or protective factors such as insight and good family support. So I like the study for taking a look at specific abstinence time periods. So this was a European cohort that looked at transplants for alcohol associated liver disease. This did not include alcoholic hepatitis. This was just cirrhosis. And they stratified their patients into high risk and low risk. To get into the high risk group, you had to be drinking for more than 11 years, more than 9 drinks a day, and you had to have failed alcohol treatment. But you can see in the 3 to 6 month group, the low risk patients look almost the same, if not better, than the patients in the 6 to 12 month high risk group and low risk group. So there is a way to identify patients who are at lower risk of relapse, and the 6 month rule becomes increasingly arbitrary when you really examine it, and is likely, at least in part, a result of stigma. So obviously, we do transplants for alcoholic hepatitis here. So what changed? And this is a multi-center prospective trial that came out in the New England Journal of Medicine in 2011. This was a Franco-Belgian trial that enrolled 26 patients with severe alcoholic hepatitis, and they were all non-responsive to medical therapy. So this was first liver decompensation. They had close family support. They had no coexisting psychiatric disorders. So these were patients who were selected for good outcomes. And they had good insight, agreed to lifelong abstinence. And everybody had to agree. The resident, the fellow, the addiction specialist, the bedside nurse. So they asked everybody to make sure that they agree that this patient was an appropriate candidate for early transplant. And then they did it. And their outcomes for patients undergoing transplantation were significantly better than their matched controls, as you would expect, given the dismal prognosis of unresponsive or steroid unresponsive patients. I would say in most of the more modern cohorts, the survival for patients undergoing transplantation is actually much better than the 77% at 6 months. So this was practice changing. So you can see this is a transplant a survey of centers performing liver transplantation for alcoholic hepatitis in the US over time. The red line is the Franco-Belgian experience. And then you can see by 2017, almost half of US centers are performing alcoholic hepatitis transplants. So this really did change the game a little bit for these very, very sick patients. And how are they doing? Well, follow-up studies have taken a look. So there's the biggest follow-up consortium was the Accelerate ALCHEP group that included 12 centers in 8 UNOS regions. And they listed about 35% of the patients that they evaluated with alcoholic hepatitis. And they had great outcomes. So 94% 1-year survival, 84% at 3 years. And sustained alcohol use after transplant was only 10% in the 1-year post and 3% in the long-term post data. Hopkins did an internal study of relapse, and they really had similar patients relapsing when they were diagnosed and transplanted for alcoholic hepatitis compared to alcoholic liver disease, about 23%. And when we're thinking about post-transplant liver or alcohol in our liver patients, we're thinking about probably that 20 to 30% relapse rate. So the Accelerate cohort actually was better than expected. And this is a really optimistic way of looking at it, but the patients who didn't get transplanted had mortality without transplant up to 70% at 6 months. So the pessimistic recap of all of this is for alcoholic liver disease, we are seeing patients late in their disease. They are sicker. 50% of cirrhosis deaths are alcohol related, and mortality is rising quickest in the youngest. And we're disqualifying 70% of highest risk of death patients for psychosocial reasons, and 70% of them are dying. So I think that should spur us all to want to make sure that we can try to intervene and treat these patients. So again, what does treatment look like? Well, 7.2% of people with alcohol use disorder receive any treatment in the past year. Less than 4% of people with alcohol use disorder were prescribed medication approved by the FDA. But abstinence in alcoholic liver disease is proven to improve outcomes, which is so frustrating about some of this treatment data. So this is a treatment trial or treatment look at private insurance cohort. So this is a US privately insured cohort with alcoholic liver disease and cirrhosis. Between 18 and 64 years old. The reason the 64-year-old cutoff is that 65 is you get Medicare. So 72% of these privately insured patients had mental health service coverage. 87% had prescription drug coverage. And when you took a look, again, these were all patients already diagnosed with alcoholic liver disease and cirrhosis. But if you follow them out to 2 years, FDA-approved alcohol relapse prevention medications, 1.2% at 2 years. Non-FDA-approved medications, 8.3% at 2 years. Mental health services, only 14% at 2 years. And unfortunately, the women were less likely to utilize the mental health services and get medications for relapse prevention. So we have this huge problem with alcoholic liver disease, but a huge gap in treatment for alcohol use disorder. This is another cohort that looked at alcohol use treatment at the VA. So this is a retrospective cohort of veterans with cirrhosis and alcohol use disorder, about 35,000 in all. Over 180 days following the index diagnosis of alcohol use disorder in these patients with cirrhosis, 14% received treatment. 12% received behavioral therapy alone, 0.4% received pharmacotherapy alone, and 1% received both. So again, very, very, very small percentage with real linkage to care. And in a very short follow-up, patients who received no treatment compared to any alcohol use disorder treatment had lower, patients with no treatment had higher risk of hepatic decompensation, and in the longer term, they had higher risk of mortality. And abstinence does help. So it is in longer trials that carry out evaluation for years as opposed to months, we see that abstinence improves survival. So this is alcoholic cirrhosis. This is a study that looked at abstinence in two cohorts of patients. One were asymptomatic patients, which means that they were referred, but they didn't have symptoms. About 50% of these asymptomatic ALD patients were actually already cirrhotic. And the second group that they looked at were decompensated cirrhotic patients. And you can see asymptomatic versus symptomatic, abstinence improved mortality. What about acute alcoholic hepatitis? This is 398 patients with corticosteroid treatment. 60% responded to steroid therapy by the Lille score, which again puts them in that high responder rate, good mortality outcomes. But 55% of the total population survived to 6 months. Short-term mortality, so if you're seeing the patient in the hospital, what are you going to use for their mortality assessment? You're going to use the MELD, and then you're going to use the Lille. You're going to use your MELD and Lille nomogram. And alcohol relapse in the short term really doesn't play a role. But once you hit long term, over 6 months, alcohol consumption was associated with increased risk of death. And it was a dose effect. So when you're comparing to 0 grams per day, even lower risk drinking, the 1 to 29 grams, increased their risk of mortality. For the 30 grams per day, hazard ratio was 3.9%. And again, the more you drink, the more likely you are to die after your acute alcoholic hepatitis diagnosis. If you're at Hillcrest right now, you're seeing a patient exactly like this playing out in the ICU. So all of us see this very frequently. What about post-transplant? Well, this is relevant post-transplant as well. You know, we've been talking about some of the sex-based differences in drinking patterns and in susceptibility to cirrhosis. We're also seeing some alarming trends in post-transplant. So the graph on the right is women. The graph on the left is men. Yellow is alcoholic liver disease. This group's cirrhosis and alcoholic hepatitis transplants. Blue is cirrhosis for other causes. The 18 to 29 and 30 to 39-year-old women had the lowest adjusted probabilities of 5-year survival at 74 and 82% respectively, compared to the same decile for non-alcoholic liver disease. These are still pretty good outcomes, but they are significantly worse than when we're transplanting either their male counterparts or their non-alcoholic liver disease counterparts. So young women less than 40 have excess mortality beyond 1 year with recurrent disease, or alcohol is the most common identified cause of death in this demographic. So abstinence is important pre-transplant, abstinence is important post-transplant, and we have huge gaps in treatment. Well, one would hope that in GI and hepatology, we're doing a good job, but that is not so. So alcohol use disorder treatment survey completed of 408 providers. This was a recently published study in 2021. And hepatology providers made up about 89% of respondents. In the US, about 80% of respondents. And almost all of them were working in a transplant center. So what did the survey say? Less than 50% use alcohol biomarkers and other validated screening tools to follow their patients. 40% believed safe alcohol use exists in patients with liver disease. And this actually increased about 70% when you look at our trainees. 61% routinely referred alcohol use disorder plus ALD patients for behavioral therapy. This is actually very good numbers. So a significantly higher rate of referrals than are sometimes seen in the community. Hepatologists felt that baclofen is actually the #1 preferred pharmacotherapy, but 71% have never prescribed it. And 50% of providers lack knowledge about FDA-approved pharmacotherapy, and 90% were really hoping to get more formal training. And we'll touch base on baclofen in a little bit when we discuss treatment. So what are barriers to treatment? Well, there are patient-level barriers to treatment, and then there are societal barriers or structural barriers to treatment, and then physician-level barriers to treatment. So structural barriers, insurance, childcare, transportation. And this is by far more often cited in our patients who are Black or Hispanic, and certainly in our patients who are in much lower income brackets. Attitude barriers, these actually are more cited by women. So this is too embarrassed or afraid of what the boss, friends, or family would think, and afraid of what a hospitalization would look like, thought that nobody could help them, or thought they were strong enough, or didn't think that the problem was serious enough. And this is really rooted in both normalization of drinking across society and the stigma associated with the diagnosis of alcohol use disorder. That is really the root of a lot of these attitude barriers. There's also barriers for readiness for change. And some of our patients may have stopped on their own and they don't feel like they need help. And some patients will just want to keep drinking or using. On the clinician side, we are seeing patients with much more severe and late stage disease. These may be somewhat different than early stage alcohol use disorder patients. They've had more consequences, more distress, and they're obviously in the liver disease patients, there may be more of a cognitive impact as well. We're not getting enough training. And medical school, 75% receive little or no training. Residency, 44%, no required curriculum in substance use disorders. In clinical practice, about a third of clinicians fail to screen for substance use disorders. We also, at the end of the day, have inadequate data. So clinical trials, especially for medications, usually exclude patients with liver disease. And data, especially in pharmacotherapy, is severely lacking in alcohol-related cirrhosis. There are 13 psychosocial intervention trials in chronic liver disease, only 7 of which are pure alcohol liver disease trials. There is 1 drug randomized controlled trial in alcoholic liver disease. 1 drug trial looked at Hep C plus alcohol, and another only 20% of their patients were alcohol use disorder. End of list. And that really is shocking for such a deadly disease. So this is the part of the talk where most of my not a psychiatrist, not a psychologist disclaimer comes from. So let's talk about what you can actually do in your clinical practice to treat and refer these patients. Number 1 is ask. So the NIAAA recommends a 1-question initial screen. How many times in the past year have you had 5 or more drinks in a day, or 4 or more drinks in a day, depending on sex? If even a single episode, you should do the full audit, and that's their recommendation. The Audit C, however, also performs really well. The Audit C is the 3-question version of the 10-question audit survey, which will ask your patient, how often do you have a drink containing alcohol? How many standard drinks containing alcohol do you have on a typical day? And how often do you have 6 or more drinks on one occasion? So how well do these questionnaires perform when we're comparing them to the performance of clinical providers? Well, there's 2 studies to look at. There's a DoD post-deployment data that looked at patients who were coming back from deployment within 30 days, and they did a evaluation with a provider, and they also did the audit. 20% of men and 29% of women with Audit C scores of 10 to 12, 12 being the maximum, were assessed as not having an alcohol problem. So trust the Audit C. the 141 consecutive patients evaluated by audit C versus a hepatologist versus an addiction specialist. So you can see hepatologists identified 31 drinkers. The audit C got to 52, and the addiction specialist got to 58. So the audit C and the addiction specialist actually performed pretty closely together. So again, this is really a plug for using some of these surveys in your clinical practice. And then there's always, I hear this a lot in clinic from trainees, patients always underestimate, maybe they're lying to me. I think sometimes that may be true. Sometimes it's just a math problem. Patients are just not very good at realizing the math. So when I talk to patients about their alcohol use, I find out what it is that they're drinking most commonly, and then I tell them some outrageous numbers. So when I find out they drink beer, I ask, is it a 6-pack a day, a 12-pack a day, or 24-pack a day, which tends to kind of normalize the experience. You also should ask the size. I think 2 weeks ago had a patient laugh at me when I said 12-pack, but he was drinking 6-pack of 24s, which is a 12-pack. So again, it's not that he was trying to fool me into thinking he was drinking less, it's just he didn't realize exactly how much he was drinking. I also verify if you are drinking San Diego fancy beer or if you're drinking Coors Light, because most of the Coors Light, Miller Lights, that group, that's 3.3% alcohol by volume. San Diego fancy beer might get you to the 7 to 8%. If your patients are drinking 40s, verify that it's beer, not malt liquor, because beer is going to be about 3.3 alcohol servings versus malt liquor may be getting closer to that 5 to 6 month mark, and it tends to be a lot cheaper. If it's wine, I ask how many glasses of wine per day, and what about on the weekend? And is the weekend Thursday through Sunday? I always assume that the weekend starts on Thursday. And then the most helpful question I find is, does a bottle of wine last you 1 or 2 days? And for patients who sometimes think that they're drinking 2 glasses of wine per day, it turns out that they're actually finishing 3/4 to a full bottle. And it's then possible to reflect back to them and say, hey, actually, it turns out that you're drinking 5 drinks per day. And what do you think about that? For mixed drinks, you should always ask how they make it. In the world of telemedicine, I've actually had patients show me what they make their drinks in, and I've seen anything from little short glasses to basically this. And half of that would be tequila. So the next question is to ask for time. How long have you been drinking? And again, most patients are just not very good at remembering how much or their quit time unless they have an official quit date. So always clarify. The other piece of this is you actually can drink Listerine and NyQuil. So Listerine is 26.9% alcohol by volume, Scope is 18.9, and NyQuil is 10% alcohol by volume. So if I'm following a patient in clinic with alcohol use disorder, I usually will tell them that one, I'm going to test them with serum biomarkers for alcohol use, and that if they're drinking Listerine or NyQuil, that will show up as alcohol and that they should not do it. And I recommend that they use non-alcoholic mouthwash. Because again, we have definitely had some serious Listerine ingestions in our patient population. So number one, ask. The next thing that you can ask is the lab. So I think most of you have seen that we've been using the PEth more and more. About 5 or 6 years ago, we were using the carbohydrate deficient transferrin before PEth became more readily available. That assay, bilirubin interferes with it, so it tends to not be super useful in your patients with liver disease. And for the urine ETG, I find it more difficult to get compliance because patients will go get their blood tests and then they say, oh, I didn't have enough urine to pee. PEth just tends to be easiest, and it catches about 2 to 3 weeks of alcohol use, but probably in our liver disease patients, it may extend up to 4 weeks for metabolites. And then keep asking. This is a chronic disease with a course that is often punctuated by relapse. How are you doing with your sobriety? check a PEth. That should be equivalent to how are your blood sugar readings at home? Check an A1C. Once you have identified a patient with high-risk drinking, what should you do? Okay, so you did your screening. The next piece is a brief intervention for your patients. And this is where you're going to be using your motivational interviewing techniques. And what you're focusing on is raising a person's awareness of his or her substance use and its consequences, and then trying to actually motivate them towards positive behavioral change, because it is their self-efficacy that is going to help them to stay sober or to reduce their alcohol use. So you want to focus on open-ended questions and affirmations. Really think about their instances of success, reinforce when they were successful, reflect what they're telling you, and then summarize key points. This is the ORS model of motivational interviewing. There's also a FRAMES model that you can use instead. That's a little bit longer, which does usually start with doing an audit or one of the other questionnaires, and then essentially giving your patient almost a report card on their drinking for their health and then compared to the general population. This is also where I find it very helpful to actually quantify the standard drinks that patients are consuming, because again, they may be actually very surprised by that information, and that may spur the motivation to change. The U.S. Preventative Services Task Force found that 6 to 12 months after a brief counseling, participants decreased their average number of drinks per week, anywhere between 13 to 34%. So this works. And then your next step can be either brief therapy if you're able to provide that, or a referral to treatment. So what referrals to treatment do you have available to you? So first is mutual aid. This is your AA and your Smart Recovery. AA is a 12-step program model, and it's religious or spiritual based. I certainly recommend familiarizing yourself with the 12 steps, because then it's easier for you to talk to patients about them. Smart Recovery is a self-management and recovery training. This really emphasizes on learning how to cope with urges and cravings. It's really based on CBT. So some of the exercises that patients do, there's still that same component as with AA, where you share your story during the beginning of the session. But after that, they actually do essentially a CBT exercise where they talk about an activating event, what were their false beliefs around that activating event, and what were the consequences of that action. AA and 12-step programs are easy to refer to. They're cheap or actually free, and they do work. So this is a Cochrane review of randomized controlled trials comparing manualized AA or 12-step programs to other clinical interventions, namely cognitive behavioral therapy in an individual therapy setting. And AA actually improved the rates of continuous abstinence at 12 months. And this improvement carried on to 24 and 36 months. So if you have patients who are who work well in a group setting, who are able to work the program, these can be actually really valuable resources for them. And again, they are free. Once you've referred to a 12-step program, circle back. How many meetings did you go to? Do you have a sponsor? Do you have the big book? Are you working the steps? Which one are you working on now? I certainly see patients in different stages of their recovery talking differently about their AA experiences, and you can certainly follow up with patients to see how they're doing and reinforce that motivation for change. For Smart Recovery, you can find out if they're sharing or if they're still just listening. And if they are sharing, what are some of the activating events that they've been working on in this group? And again, kind of reinforcing that you are a partner with them in their sobriety, as well as in their liver disease or other chronic disease that you're treating. Then after these referrals, the next set of referrals is referring outward to more traditional services. So outpatient services, UCSD dual diagnosis does not accept Medi-Cal. So, half of Hillcrest can't go there. Other services besides kind of the traditional outpatient services are detox, IOPs, which are really intensive group therapies, usually half days, 1 to 4 days a week. And then escalating in intensity, partial hospitalizations, usually full days, 5 days a week. Residential treatment, where patients will live there under around-the-clock supervision, and the variety of therapeutic activities there. And then there's inpatient, which is a little different than residential, because this has a more intensive medical or psychiatric component. This is really good for patients who have a serious coexisting mental illness. So how do you find these places? The NIAAA Navigator is one useful tool. So this is the website for them. Basically, you plug in your zip code, and then you can filter by Spanish speaking, by Medicaid or Medicare, and the type of treatment that you're looking for, outpatient, residential, or you're looking for just telemedicine. So I find this website to be a really useful resource for patients. There's also a San Diego County funded programs resource. So this is the website for them. And essentially, when you look and you're looking for addiction recovery services, they will group the services under dual diagnosis, drug use related, companionship, custody issues. So you can have a different resources that you refer patients to. If your patient can't use the internet, they can just call the San Diego crisis line, and they can also call 211 in order to get hooked up to care. Once you have referred, again, circle back. Patients have to be really motivated to get into certain programs. You have to call multiple times. You have to leave messages. And patients have to be the ones that call, and family cannot call for them. So usually if I'm referring out, I tell patients this, that they need to call, that their auntie or their best friend cannot call for them. And then even when we're referring patients, this is Castle Palmera as an example. Look on the right for insurance coverage. Health Net, no PPO coverage. Magellan, whatever that is, no detox coverage. Multi-plan, depends on which plan. Opt-in may not be approving you for inpatient opiate diagnoses. So there is a second layer where patients may have to call multiple places to actually find somewhere that takes their insurance. This is hard work. You have to be really motivated. And it's important to try to encourage your patients to do this. Some resources are pretty variable quality, and some patients are not forthcoming with their therapist. So the other part of circle back is, did you talk to your therapist about your alcohol use? And does your therapist know that you are not on the transplant list because of your recent alcohol relapse? And that I really find to be an important gateway into figuring out whether or not they're actually getting therapy for their substance use. So getting to treatment, psychosocial interventions, when we have alcoholic liver disease and alcohol use disorder. I told you that there was 13 trials. Here they are. This was a randomized, this was a review of all of the psychosocial interventions in patients with chronic liver disease. Only 7 trials included just alcoholic liver disease. And therapies worked. The proportion of patients reporting abstinence was higher in patients who had an intervention compared to controls. And in patients who integrated cognitive behavioral therapy and medical care had significantly smaller rate of relapse. What about post-transplant? So, big secret is that transplant does not cure alcohol use disorder. Transplant cures alcoholic cirrhosis and alcoholic hepatitis. So this is a study of 118 patients, and you can look at the black bar is no substance abuse treatment pre-transplant or post, pre-liver transplant substance use treatment, or post and pre-substance use treatment. And it's the patients who treat this, and when we treat this as a chronic disease, pre and post-transplant, that patients are much more successful with their abstinence. So what about medications? The American Psychiatric Association recommends that our 1B recommendation is naltrexone or camprosate. Now, they also suggest disulfiram, and they suggest topamax and gabapentin as other potential treatments. Now, when you look at the ASLD and you're trying to look at patients who are alcohol use plus alcoholic liver disease. The AASLD actually says, based on limited data, they're recommending acamprosate and baclofen. And disulfiram's not even on the list for AASLD because it's well described to cause acute liver injury and liver failure. So we really don't feel comfortable using it in patients with alcoholic liver disease. So what's actually prescribed? Well, we talked about that survey of GI and hepatology prescribers. So again, AASLD likes baclofen. We have one RCT on baclofen. So it did seem if you were being prescribed medications by a hepatology provider, you were more likely to prescribe baclofen if you were cirrhotic or non-cirrhotic. Other prescriptions were for gabapentin, for naltrexone, but that third bar is liver transplant recipients. You can see that liver transplant recipients were actually much, much less likely to receive any therapies. And again, I reiterate, transplant does not cure alcohol use disorder. On the right is that private insurance treatment graph. So this is what patients with alcoholic liver disease in a private insurance setting, when they were being followed by mental health professionals, this is what they were receiving. So again, this was a big mix. Gabapentin was 69% of that mix. But of the FDA approved ones, it was primarily acamprosate and naltrexone and disulfiram, but again, in very small numbers. So why the buzz about baclofen? Baclofen is really the only RCT that we have. So the concerns with baclofen are for hepatic encephalopathy, and the trials have excluded patients with HE. So the RCT that happened in alcoholic liver disease had a positive result, but a study with 20% alcohol liver disease also showed a significant effect of baclofen use over time. But overall abstinence rates with baclofen were very low. In a VA study that looked at Hep C plus alcohol use disorder, there really was no difference. And realistically, the reason it's not recommended by the APA is that in non-liver disease settings, it has really not been shown to work. But this is the trial that made hepatologists be more likely to prescribe this. So this was an 84-person trial in Italy, randomizing to baclofen or placebo, and 71% of patients allocated to baclofen achieved and maintained abstinence, compared with 29% of those on placebo. There were no hepatic side effects. And the main thing that you should remember about most of these interventional trials is that there are frequent medical visits. Some form of counseling intervention is given. And these are really better described as integrated therapy. Acamprosate we'll gloss over just because of time. This affects multiple neurotransmitters. Really no data for this drug specific to alcoholic liver disease. And the data for European cohorts versus American cohorts in using acamprosate is very mixed. Some of the criticism of the US-based trial for acamprosate is acamprosate tends to work better once you've actually been abstinent for a little bit of time. And most of the US-based data, there probably wasn't enough of a detox period. The problem with acamprosate, just like baclofen, is that it's a TID medicine. You know how much your patients love TID medications. So it's a big compliance issue, I found. And then naltrexone, and we'll just close with this. So this is an opioid receptor agonist. An effect is due to reduction of alcohol-related dopamine release, and really a reduction in the reward sensation from alcohol. There is a black box warning for liver injury. This black box warning came from a study looking at obesity, and they were giving patients naltrexone doses of 300 versus doses of alcohol use disorder of 25 to 50 milligrams. The chance of liver injury if you're looking at liver tox, is very small. There's really no definitive link to clinically apparent liver injury in the smaller doses. But in our cirrhotic patients, there is actually issues with clearance of naltrexone. So certainly the AASLD, the APA, all recommend caution in patients with the severest forms of liver disease, and they may need a really more significant dose reduction. So I think we should just end there. The residents were sent the combined trial, which looks at alcohol abstinence in non-ALD with acamprosate and naltrexone, and you could peruse that. But I think we should again conclude in the interest of time. So 15 million people in the US have alcohol use disorder. This is a huge problem. Our patients are dying, and we need to do better at treating them.
Dr. Vodkin, thank you so much for that important and thought-provoking presentation. We do have a couple of questions. Let's see if we have time for at least one of them. From Dr. Hasty, one of our chief residents, are there any differences in rates of alcoholic hepatitis in regions of the country that have legal restrictions on access to alcohol? Are there differences in parts of the world that have different legal drinking ages?
Yes, so there are huge differences, but because this talk started out as 107 slides, I cut out the 10 on this exact question. So you can actually, the nicest study that's come out recently is out of Latin America, and they looked at 8 different public health interventions. When they looked at those 8 different public health interventions, the more public health interventions a country had, the lower their risk of alcohol related mortality and morbidity. The same thing happens across states. So there's also a nice review that looks at the US, where kind of the more restrictions you have, the more you are decreasing rates of admissions and hospitalizations due to alcohol. And in other countries that have implemented, probably the most well-studied and the most robust data is actually for taxation and the minimal use price or minimal unit price. And you can see in Scotland, as soon as the minimal unit price was implemented, plummeted the risk of high-risk drinking in patients who were the most vulnerable. So lowest socioeconomic classes, who were really the most vulnerable to, again, living next to a liquor store, having social isolation, and having poor access to healthcare. So public health interventions work, but if you look at the US, the taxation rate on alcohol since the 60s has plummeted. And again, I could drink a pint of vodka per day for $15. And if I was really fancy and I wanted that vodka to be Kettle One, it would be $30 a week.
Thank you, Dr. Vodkin. We'll try to squeeze in a couple more questions. Do you think physicians lack knowledge about safe drinking levels in patients with alcohol liver disease? Is this related to physicians' own drinking habits?
I think potentially. I think that the patients with liver disease, I think if you're seeing a patient with alcoholic liver disease, it's a pretty no-brainer to say you can't drink anymore. But when we're looking at patients with other forms of liver disease, I do find that sometimes the amount of alcohol they're drinking is underreported and under-asked, because you're less likely to say, well, you have Hep C or you have hemochromatosis, so maybe we should also still be looking for that acceleration. And there is some emerging data from patients with fatty liver. And if you start to stack fatty liver and obesity together and you put in even modest drinking, you are going to have a worse effect on survival. And I think that data is emerging, and it's not looking at heavy drinkers. It's actually looking at modest drinking, so things that are felt to be even more socially acceptable. So yes, I think that there's some emerging data that's going to be really valuable in reframing the amount of drinking that's safe for patients with liver disease overall. But I agree, I think that there's such a societal normalization to alcohol use, and especially for wine, I would say, that I do think that bleeds into our clinical practice.
And then maybe one quick practical question from Dr. Raffleson, one of our residents. Are you comfortable using long-acting IM naltrexone in patients who have never had it before orally, or should we be starting oral first to see if patients tolerate it?
That's a tough question because my population is so enriched for patients who are really cirrhotic from their alcohol use or have pretty advanced liver disease because of all of the caveats and the concerns with cirrhosis for the bioavailability of naltrexone. I tend to use naltrexone over Vivitrol, which is the injectable. I would feel much more comfortable with somebody who just had an alcohol use disorder without co-occurring liver disease, just going straight to Vivitrol. But for patients who already have alcoholic liver disease and cirrhosis, just the bioavailability makes me a little bit uncomfortable to go straight to the, you are now committed for a month.
Thank you, Dr. Vodkin. And this question may require too detailed an answer for the time that we have, but from Dr. Lumba, among patients who have alcoholic hepatitis admitted to UCSD, how do you decide who gets a liver transplant and who does not?
So I think that we now have a policy in place. And actually really, I think back in the day, it was a little bit more of a hodgepodge of who gets to decide and how we decide. And there was a difference in referrals, right? You have to first think about the patient as a transplant candidate and then refer them. So it takes a lot of kind of physician initiation versus with the fact that we now have a protocol. The protocol is relatively clear. And we do, I think most programs right now will take a look at more of the Franco-Belgian type of rubric. Again, the non-responders, the ones with the mortality. But again, your first episode, you don't have a lot of comorbid diseases, you have good insight. So kind of that same model of lower risk patients. And I think that's what's nice about having the protocol is that you're just more likely to refer. So my usual instinct now, if I see a patient with alcoholic hepatitis and I'm rounding with a fellow and I'm rounding with my NP, I just say, okay, can we transplant them? Okay, but why not? So I think it's been much easier now to frame the question as, okay, can we transplant? As opposed to before when we do have a set of guidelines in place. And it's really tough to with the 6 months, sometimes with insurance companies. What we were really running into a couple of years ago was that Medi-Cal refused to do this. So we essentially had patients that were being completely disadvantaged by their payer status. And we were able to transplant the same patient if they had Blue Cross. That has gone away, at least for acute alcoholic hepatitis, but not for alcoholic cirrhosis, where Medi-Cal still demands a 6 months arbitrary sobriety limit. So again, I think I ask everybody if they could be a transplant candidate, but we are still struggling with some of that payer mix in getting this done.
Outstanding. Thank you so much, Dr. Vodkin. We really appreciate your talk. Have a great day, everyone, and please join us next week for another Department of Medicine Grand Rounds.